My name is Flavio Roca, and on behalf of my co-authors from the Digestive Disease Institute at Virginia Mason in Seattle, I've had the opportunity to present our poster, which is Similar Outcomes of Sterile versus Infected Walled-Off Necrosis Treated with Combined Endoscopic and Percutaneous Drainage. Infected walled-off pancreatic necrosis, or WON, is considered the major indication for surgical debridement and is thought to have a poorer outcome than symptomatic sterile necrosis. Our group has previously developed a minimally invasive drainage procedure by combining endoscopic and percutaneous drains that has reduced length of hospitalization, resource utilization, and eliminated pancreatic cutaneous fistula compared to percutaneous drainage alone. We sought to determine if infected necrosis was associated with significantly different outcomes compared to sterile necrosis in patients treated with this dual modality drainage. We reviewed an IRB-approved prospective database of all dual modality drainage treated walled-off necrosis between 2007 and 2014. Demographic, clinical, and procedural data was collected from the medical record and analyzed. Infected necrosis was defined solely by the presence of culture-positive aspirates on the first access to the necrosis. Statistical tests, including the student t-test and a chi-square test, were used to determine differences between groups. Our results: out of 134 consecutive patients with necrosis who had dual modality drainage, 71 had sterile aspirates, while 63 had infected necrosis. If we look on Figure 1, the patient flow for these patients, we see the patients that were treated with dual modality drainage highlighted in red. And of this group, the sterile necrosis and the infected necrosis and their outcomes. All but 2 completed dual modality drainage in the sterile group. There were 2 deaths, and no patients needed any acute operations for their necrosis. Out of the infected cohort, 63 completed the dual modality drainage. There were 3 deaths. 2 patients still have drains in place, and there were no patients that had an acute operation. If we then turn to Table 1 and look at the demographic information, the patients in the infected cohort were statistically older, had a longer ICU stay, and had more fistula that were noted. However, there was no difference in the etiology of pancreatitis or sex or whether they were transferred to our institution. In addition, they did have a higher CT severity index, but had no difference in the disconnected main pancreatic duct. Moving to Table 2, the clinical outcomes, the infected cohort had more drains placed per patient, required more endoscopies per patient, and had a longer length of stay. However, there was no difference in the number of CAT scans, tubes, or drain exchanges, interval till drains were removed, complications, or deaths. In Figure 2, you'll see a typical patient. On the left panel, you'll see the walled-off necrosis, which is quite mature, and this is pre-dual modality drainage. And the panel on the right, you'll see the patient after treatment with dual modality drainage, where you see complete resolution of the walled-off necrosis. And again, no patients required acute surgical operations. In Figure 3, the panels highlight the technique of dual modality drainage. The panel on the top left demonstrates the initial puncture, which was typically performed using endoscopic ultrasound access with pus emanating from the collection. In the bottom panels, you'll see the percutaneous drains in place, and then the endoscopic stents being deployed using those as a guide. And there you have a completed dual modality drainage. So in summary, although patients with infected walled-off pancreatic necrosis are older, have higher CT severity indices, more drains, endoscopies, and fistula, and required longer ICU and hospital stays, they had a similar outcome compared to walled-off necrosis in a sterile cohort following dual modality drainage. Therefore, infected walled-off pancreatic necrosis can be managed safely with non-surgical techniques, but may require additional interventions for complete resolution. Thank you.